Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I'm Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai. Thank you very much for joining me for this 298th episode of the podcast as we move forward to our milestone 300th episode in just 2 weeks. I hope everybody enjoyed last week's episode on the topic of pulmonary atresia with intact ventricular septum. We spoke with Dr. Elias Iliopoulos of Inova Medical Center in Virginia, and for those of you with an interest in congenital heart disease and outcomes research, I'd certainly recommend you take a listen to last week's episode with Dr. Iliopoulos. As I say most weeks, if you'd like to get in touch with me, it's easy to remember my email. It's pediheart@gmail.com. This week, move on to the world of electrophysiology, to a very interesting practical paper. The title of the work we'll be reviewing is Safety of Same-Day Discharge Without Anticoagulation for Left-Sided Radiofrequency Catheter Ablation in Pediatrics. The first author of this work is Vincent Palmieri, and the senior author, Robert Whitehill. And this work comes to us from Children's Healthcare of Atlanta Cardiology in Atlanta, Georgia. When we're done reviewing the paper, the first author of this work, Dr. Vincent Palmieri, who is an advanced electrophysiology fellow at Children's Healthcare of Atlanta, has kindly agreed to speak with us about it. Therefore, let's move on to this article and then a conversation with its first author. This week's work begins with a few comments about how ablation of left-sided SVT arrhythmias in children is generally safe, but that ablating on the systemic side of the circulation can potentially stimulate the coagulation cascade, with some risk for stroke or blood clot formation. And they review how, though the incidence of these events was reported in early literature on ablation to be roughly 2%, more recent work suggests that this risk is likely below 1%. Based on this information, most pediatric practices will use some form of post-ablation anticoagulation following a left-sided ablation, and this is largely based on adult data on this topic. However, there is substantial variability on the use of any anticoagulant in this setting. With this as a background, the authors sought to determine what the outcomes were after SVT ablations on the left side, in which patients were sent home on the same day, with the goal of describing these outcomes and also trying to tease out if short-term aspirin, which is certainly the most commonly used agent in this setting, is of benefit, or if not treating is associated with more or less complications. This study was retrospective and single-center over a 10-year period from January 2010 till July 2020, and included all kids having left-sided ablations less than 21 years of age at Children's Healthcare of Atlanta. If a patient was lost to follow-up after the ablation, they were excluded. The authors explained that in Atlanta, all children receive intermittent heparin boluses in doses of 50 to 100 units per kilo to maintain an ACT between 200 and 350 seconds, and that all patients were monitored 3 to 4 hours post-ablation. Different providers in Atlanta had different practices, from no aspirin to 81 milligrams of aspirin every day for 4 weeks, and this decision was based upon doctor preference. The authors explained that they recommend a follow-up 1 month and then 1 year after ablation, and that patients are generally then discharged from cardiology follow-up thereafter. For this work, the primary outcome was development of an anticoagulation-related complication within 1 month of a left heart cath, including things like blood clots, excessive bleeding, and vascular complications. Information on migraine headaches were also included, and once again, patients who had no communication or follow-up after ablation were not included for analysis. And on to the results. 376 patients were included who all had left heart ablations for SVT, and the median age was 13.9, with nearly 80% being Caucasian. 96% had a structurally normal heart. Of the 14, or 3.7%, who had some form of structural heart disease, 4 had a bicuspid aortic valve, 3 had single ventricle physiology, 1 had a Ross operation, and 1 was a transplant patient, so basically the vast majority had normal structural hearts. In this cohort of 376 patients, 300 did not receive aspirin, and 76 did. And the authors explained that 85% of patients required an actual transeptal puncture to cross the septum, and about 12% had a foramen that was adequately open for the operators to just pass a catheter through it. A small percentage, less than 3%, had a retrograde approach to the left side. So basically, 20% of patients in Atlanta during this time period received aspirin post left-sided SVT ablation. The most common SVT substrate was WPW in 49%, followed by concealed accessory pathways in 42%, and ectopic atrial tachycardia in 10 patients, or 2.7%. In those patients in which the data was obtained, the procedural time average was 150 minutes, with a median number of RF applications being 7, and a total of 286 seconds of ablation per patient. The majority, or 90%, adding up to 338 patients, were discharged on the day of ablation. Follow-up was obtained in 73%, or 273 patients, with an average follow-up of 399 days. In this group, as in the overall group, the majority, or 78%, were not treated with aspirin, but 22% were at discharge. One patient, or 1.6%, who was prescribed aspirin had a migraine, and 6 patients, or 2.8%, who were not prescribed aspirin had bruising in the groin in 5 and an unspecified headache in 1. And Table 4 of this paper basically shows that these data did not demonstrate enhanced or reduced risk with aspirin versus those who did not take aspirin in regards to these complications. In other words, there was no statistically significant correlation between anticoagulation complications or migraines with same-day discharge or aspirin administration. Importantly, there were no TIAs or significant clots at 1-month follow-up. In their discussion, the authors stated, and I quote, "Given the rare risk of thromboembolic complications in pediatric patients undergoing left-sided cardiac ablations, same-day discharge without aspirin may be considered for some patients. We did not find any benefit or an increased complication rate associated with aspirin administration after left heart catheterization ablation in our cohort. There were no serious thromboembolic complications, and the rare complications that occurred were minor and self-resolving in nature." The authors also make the point that the same-day discharge was not associated with any serious thromboembolic or rebleeding episodes, suggesting that sending home on the day of cath for a left-sided ablation was also safe. They explain that in their practice, the most common reason that anyone with a left-sided ablation got admitted was because of a late end time for the case, though there were rare patients with the excess site bleeding or those who had arrhythmias that still needed treatment after ablation. They review how left-sided ablation patients going home on the day of the procedure have been shown to be generally safe in prior works, and even as safe in those having AFib ablations in the adult population, and they reference how these observations were particularly important given the recent COVID pandemic and the need for beds, not to mention that sending patients home is generally less expensive. The authors explain that though many centers recommend a short course of anticoagulation in this setting, there's essentially no data in the literature to support this, and that the findings herein are supportive as there were no associated complications attributable to not giving aspirin after left-sided ablation. In reference to limitation of this study, the authors mention the small patient population and low complication rate, which limits statistical power. They mention also the 27% of patients who did not follow up in clinic, and how this biases results both in terms of success, which the authors noted was 97.8% in follow-up, as well as in regards to complication rates. They mention limitations also in their database in accurately remembering the number of RF applications or procedural duration in all cases, and they do not have all the data on why all of the patients who were monitored overnight were in fact so monitored. They also mention the single-center and retrospective nature of this work as further limitations. And so they conclude, given the rare incidence of thromboembolic complications in pediatric patients undergoing left-sided cardiac ablation for SVT, same-day discharge without aspirin should be considered. There is no added benefit or increased complication rate associated with post-procedure aspirin use, although larger studies are warranted due to low frequency of complications in this population. Well, this is an interesting work basically showing that no one in Atlanta over a 10-year period seemed to have a serious thromboembolic complication with a left-sided ablation, whether they were treated with aspirin or not after cath, and also showing that sending most of these patients home on the same day as cath was not associated with more or fewer complications. This is notable and worthy of presenting. However, I would certainly put up a word of caution and echo the author's own final words that the low frequency of complications in this patient group likely do make it challenging to know if these data are adequate to warrant a policy of discontinuation of aspirin to those who have otherwise normal hearts other than SVT. This work clearly shows that it is very rare to have a serious problem, and also that there was no difference in those treated with aspirin or not. However, given the generally low complication rate of this in pediatric ablation, it's very hard to know from these data if this is enough to change one's policy. As some of you know who listen to the podcast, I'm a bit of an oddball in this field in that I perform both EP procedures and am also an interventional cardiologist, and so I have an unusual perspective as someone performing invasive procedures on both EP patients and congenital heart patients. I think it would be fair to say that though any invasive procedure always should cause some nervousness or anxiety in the operator, EP cases are generally, for me, more anxiety-provoking. And why is that? Well, I think the reason is that these are generally very healthy patients whose only problem is SVT. When that patient enters the cath lab, anything other than leaving the lab exactly as they entered, and hopefully better, is simply unacceptable. Yes, this is certainly just as true in interventional cases, but it has always been my impression that even the most minor of cath-related complications in the EP patient is far less well tolerated than congenital heart patients. Any experienced EP doctor knows the frustration of dealing with a post-cath corneal abrasion or a minor pressure sore on a heel that was not properly padded, and knows how difficult these transient problems can be for this patient group and their family. A stroke would clearly be orders of magnitude worse. And so, though I agree with the general message of this work that stroke risk is likely not affected by aspirin in this setting, I am not sure that these data are yet enough to make me change my own practice of post-cath aspirin in left-sided ablations. My general opinion is that it is cheap, has a very high therapeutic index, and might be doing something positive, and in the absence of known complications from it, the enemy of good might be better. However, this work certainly has given me and others pause, and so it's useful to challenge convention, just as this work has done. In regards to the notion of going home on the same day, in a sense, one could say that the horse has left the barn, as most electrophysiologists understand that insurance companies in the United States no longer allow overnight stays unless there is a new clinical concern. And so, though there may be no routine major advantage to this policy of overnight stay after left-sided ablation, I think we'll never know because we'll never be able to compare these two approaches given the financial impact that this decision has for the insurance company. At this point, I think we should move forward to our conversation with the work's first author, Dr. Palmieri. Vincent Palmieri is an EP Fellow at Children's Healthcare of Atlanta. Dr. Palmieri is a graduate of the College of Charleston, followed by medical school at the Medical University of South Carolina. He completed his residency in pediatrics and fellowship in general cardiology at Emory Heart Center. It is a delight to welcome him to the podcast to discuss his work. Welcome, Dr. Palmieri, to Pediheart. I'm here now with Vinny Palmieri of Children's Healthcare of Atlanta. Vinny, thank you very much for joining me this week on the podcast.
Thank you so much for inviting me to be here. It's truly an honor.
It's a great pleasure to have you. All fair, Dr. Palmieri tells me that his first experience was actually at the cath lab at Montefiore with me and Chris Jansen many years ago, so I'm very excited, and
That's right.
Maybe we had a tiny little bit to do with his interest in EP a million years ago.
Absolutely. I couldn't tell you what I saw or what was going on, but I know that it felt like the future, and I fell in love with it.
Well, that's great to hear. Well, Vinny, I often will start out conversation about the papers that we review by asking the author to maybe summarize what they think are the 3 or 4 most important findings of their work, and I'm wondering if you might be able to share those thoughts with the audience today.
Sure. The main takeaways from our study are that for pediatric patients undergoing a left-sided RF ablation, same-day discharge is safe. There is no added benefit or increased complication rate associated with a 4-week course of daily low-dose aspirin after the procedure. These procedures have a high acute and sustained success rate, and severe thromboembolic complications are very rare in pediatrics, with 0 in our study.
Yeah, all those points came out really loud and clear, and thank you for clarifying that for the audience. That's great. As you know, aspirin use is fairly common after a pediatric left-sided ablation, and I must admit that I am in that category of doctors who do that and have ever since Dr. Ed Walsh, Dr. Phil Saul, and Dr. John Treidman told me to do that in 1996. So, historically, I'm wondering, though, why did we start doing that? What was the What was the basis for giving aspirin for left-sided ablations in the past?
So yeah, I totally agree. Radiofrequency ablation in general is a known disruptor of the endothelium via resistive heating of tissue and causes a zone of tissue necrosis surrounded by a hemorrhagic zone. This causes a nidus for clot formation with potential risk for systemic embolization. And like you mentioned, starting in the late 80s, early 90s, as cardiac ablation became more widespread, especially in adults for atrial fibrillation, these events were reported in somewhere between 0.4 and 2% of procedures, with less than 1% in pediatrics. And looking back through guidelines and studies as far back as this time, it seems like aspirin was empirically used for its antiplatelet properties to mitigate this risk. And this was based on sound physiology, given the hypercoagulable state during and after procedure, but there was no actual data demonstrating any protective clinical benefit. Eventually, with the legends talking about using aspirin and recommending it, the use of aspirin became essentially dogma, and it became hard to argue against prescribing aspirin, as it's a relatively benign drug for most patients, and the theoretical risks of thromboembolic events are so severe. This was reflected in last year's PACES survey related to thromboembolism prophylaxis practices, with 97% of the 73 participants prescribing low-dose aspirin after left-sided ablation.
Wow.
The most common time frames were 4, 6, 12, and 8 weeks, respectively. And when looking at the guidelines, the most recent AHA guidelines in 2013 listed low-dose aspirin for 6 to 8 weeks as a Class 2A recommendation, largely based on expert opinion. The most recent European Heart Rhythm Association guidelines in 2015 did not recommend aspirin, and the most recent JACC guidelines published earlier this month noted that there is no clear evidence supporting post-interventional use of aspirin, but it may be considered in the setting of extensive ablation in the left chamber, which was a level of evidence C recommendation.
I see. Well, your work suggests, as you've already mentioned to us in your summary of your paper, that the use of aspirin was not associated with statistically lower incidence of complications, nor was the incidence of complications higher in those who did not receive aspirin. Now, in the adult world, though, and you hinted a little bit at this, there's quite a bit of literature regarding thrombi on catheters during AFib ablations. And the reason we know this, of course, is because in the world of atrial fibrillation ablation, intravascular ultrasound is quite routinely used, and so there's quite an extensive literature on thrombi developing in catheters, which is one of the reasons I believe why they keep their ACT very, very high and monitor it very, very closely during these procedures. And yet in pediatrics, of course, we do heparinize everyone, and I know that in your paper you describe the heparinization goals in the group in Atlanta, and you keep your ACT in the 250 range or so. But why do you believe that in pediatrics, aspirin might be less necessary than in our adult patients? So do you think it is that just pediatric patients don't develop as many thrombi as our adult patients?
Yeah, so I think the answer is multifold. So when comparing atrial fibrillation ablations in adults to SVT ablations in pediatrics, there's several key differences.
Yeah.
First, our patients are younger with less or no thromboembolic risk factors. Regarding the ablation procedures themselves, we typically place fewer radiofrequency lesions in our paper with a median number of ablations of 7 that are usually targeted to only one area of interest, such as an accessory pathway, an ectopic atrial focus, or an extension of AVNRT. Adult atrial fibrillation ablations, on the other hand, involve numerous RF lesions, 5-10-fold to ours, to a significantly greater geographical distribution, with the goal of electrically isolating all the pulmonary veins. This spread of RF energy across the left atrium has the potential for much more endothelial disruption. And while our median total ablation time was around 4.5 minutes, this can be anywhere from 15 to 80 minutes of ablation time in adult atrial fibrillation ablations. Regarding thrombus formation on catheters, it's worth noting that adults are more likely to approach the left atrium via transeptal approach using a larger steerable sheath, such as an Agilis, with an outer dimension closer to 12 French. And as you mentioned, they typically have an ICE catheter in place with an outer dimension of 10 French. This poses a greater risk of clot formation than our practice of using a single long sheath with an outer dimension of 8 French and no ICE catheter.
Yeah.
Catheter-associated thrombus has, as you mentioned, been demonstrated in the literature with Brown et al. Reporting an incidence as high as 9% in the Journal of Interventional Cardiac Electrophysiology about 16 years ago. But this group also showed that by giving heparin boluses as soon as femoral access is obtained, the incidence of left atrial thrombi detection with ice is significantly minimized. Not to muddle the picture completely, but an early heparinization would also make the consequences of potential cardiac tamponade during transeptal approach, which is a rare but non-zero risk, much more severe. So that has to be taken into consideration.
Yeah, it's always interested me. Most pediatric electrophysiologists do not heparinize until we have achieved access in the left atrium. And so it's always that the data you just reported from 16 years ago has always worried me ever so slightly. That, but of course, the other concern is exactly what you just said, which is that if the needle and the sheath happen to be in the wrong place, the consequences are even more severe if you're fully heparinized. So a little bit of competing interests. Vince, I was wondering, do you believe that there's adequate power in your work to confidently suggest that aspirin is not necessary, given that we believe that the likelihood of a neurologic or other serious complication after a left-side ablation is quite low? And although you have a very large number of patients for a pediatric study, nearly 400, it's still a relatively small group of patients for studying something that is fairly unusual.
I totally agree, and I do not think that the study alone would allow me to confidently suggest aspirin is not necessary, as I agree that it does not have the power to capture such a rare complication. I do think, though, that in the present landscape of pediatric EP, in which at the HRS conference earlier this month, they had a session as on the nose as we do it, but why? What's the data? It's important to publish these types of studies that question central dogma that isn't data-driven. And at that conference, or in that session rather, Raina Tan from NYU gave an excellent talk on a very similar topic to this. And I'd encourage anyone with virtual access to listen to it because it was, I think, 8 a.m. on a Saturday. But hopefully this study encourages more centers to look at their anticoagulation strategies, and a multi-center study emerges in the future. Last week, during your discussion with Dr. Iliopoulos, you alluded to the notion that standardization and protocol development leads to better outcomes, and anticoagulation practices for this type of procedure have a great deal of practice variability across heart centers, and it's really ripe for standardization.
Yeah, I certainly think there's adequate equipoise for a big study, because we really don't know the answer to this question. So, but for sure, I would be in agreement. Well, for those in the audience, it's a little bit late on Wednesday evening before release of the podcast. Dr. Palmieri was really nice to join us, so I'm going to finish up with the hardest question of all, which is, based on your analysis of your work and other works on this topic, I'm wondering if you could offer to the audience what you believe is a reasonable approach to anticoagulation following ablation. Who needs it, if any? And if so, what agent and at what dosing?
So I think in general, it's hard to advocate for making a change when the potential risks are so great. However, the risks historically are so low that I think operators should strongly consider not using aspirin as their baseline procedure, and instead ask themselves what the indication for aspirin would be in their particular patient. So if the patient has significant congenital heart disease, such as single ventricle physiology, cardiac shunt or conduit, cardiomyopathy, a family history of clotting disorder or stroke, or comorbidities that would lead to a hypocoagulable state, it would be reasonable to prescribe aspirin. Additionally, if the procedure, if there is difficulty approaching the left side of the heart, an excessive number of RF lesions are delivered, extensive time spent mapping, the need for a larger sheath, such as an Agilis, or a larger mapping catheter, such as an HD grid, I also think aspirin would be reasonable. And then if aspirin is prescribed, I would strongly consider same-day discharge with 81 milligrams daily, about 1 to 4 milligrams per kilogram, for 4 weeks. Largely because this is a practice that aligns with our follow-up timeline where we see our patients after 4 weeks.
I see.
And finally, I think it is worth restating the potential benefit of practice standardization across our field, in concert with potential multi-center study to increase the impact of this recommendation.
All outstanding points, and definitely things I'm going to think about strongly. Well, Vinny, I can't thank you enough for joining us this week. A very important practical paper that really questions our daily practice, and that's exactly the kind of thing I enjoy reviewing on the podcast. I want to congratulate you and all of your wonderful co-investigators, many of whom I personally know, and also want to wish you very well in your career, which is about to start as a full-time pediatric electrophysiologist and congenital electrophysiologist. Thank you very much for joining us this week on the podcast.
Thank you so much, Dr. Pass. I appreciate it.
Great pleasure. Well, as I'm apt to say, when the guest is good, there's not a whole lot more to say. I do think that Vinny has really given me a lot to think about regarding my bias towards giving aspirin to my patients following left-sided ablations. It's a tough call. On the one hand, it seems clear that the risks of not giving aspirin in an otherwise healthy ablation patient are likely very low. And yet, as we discussed, the risk for this complication is likely also low at below 1%, and the consequences quite dire. I think his comments about this being a topic that might benefit from a multicenter study to once and for all prove or disprove its need in this setting might make sense. Then again, perhaps there are more important questions in our field. Hard to know. What I do know, however, is that with young, up-and-coming, thoughtful superstars like Dr. Palmieri, the field is certainly in excellent hands going into the future. I'd like to thank him for taking time from his very busy schedule as an electrophysiology fellow to speak with us this week on the podcast. To conclude this 298th episode of Pediheart Pediatric Cardiology today, we end with one of the most beautiful of all songs in the song repertoire, and this is the Petrarch sonnet song of Franz Liszt, and the one we'll be hearing is the very challenging I vidi in terra angelici costumi, which translates roughly, I saw angelic virtue on earth, and we hear it today sung by the up-and-coming spectacular Ukrainian tenor Vasyl Solodky, who lives and studies in Italy, but is rapidly winning competitions in singing and is starting to sing throughout Europe and beyond. This is a very challenging and beautiful piece, and can only be sung by tenors who have a wonderful free top, as Mr. Solodky demonstrates in this performance. Thank you very much for joining me this week for the podcast, and thanks once again to Dr. Palmieri. I hope all have a good week ahead as we work our way up to our milestone 300th episode in just 2 more weeks.
much.